And welcome to today's CID Speaker Series event. I'm Sarah Luttrell, the Communications and Events Manager at the Center for International Development at Harvard. I'm really excited for today, as I know all of you are, for this presentation on a smart containment approach to COVID-19. The presentation will take about 20 to 25 minutes, and then we'll have about 15 minutes left for Q&A. During the question and answer session, as usual, please put your questions into the chat or using the raise your hand functions that you can ask your question directly of the speaker. Today we have CID Student Ambassador Anna Alvarez, who will be moderating the Q&A session, and she'll be taking your questions in batches of 3 to ask the speaker. We're also recording today's session, and this session will be available on CID's YouTube channel. I will also add links in the chat to subscribe to CID's newsletter, as well as to our social media channels, so you can hear more about events like this in the future. The next Speaker Series event is next Friday on November 20th with Jenny Perlman-Robinson and Molly Curtis of the Center for Universal Education at the Brookings Institution. They'll be presenting on their Millions Learning Project, which is examining scaling up quality education globally. So we're also looking forward and hope that you'll join us for that event next week. But without further ado, the event that you're all here for today, I would like to introduce our speaker, Asim Khwaja. Asim is the director at the Center for International Development at Harvard, as well as the Sumitomo-Foundation for Advanced Studies on International Development Professor of International Finance and Development at the Harvard Kennedy School. He's also the co-founder of the Center for Economic Research in Pakistan. So thank you for being here today, Asim, and I will hand it over to you.
Great, thanks, Sarah. Let me just jump to my screen. Give me 1 second. Hopefully you guys are able to see my screen. Just give me 1 second. Okay.
And I've also just shared in the chat links to resources for today's talk. So if you're interested in seeing the report or other items that Asim's going to talk about, you can click the links right in the chat.
Great. Well, thank you, everyone. Sorry for that delayed start. So I kind of have 3 objectives today, so I'll try to be pretty quick about it because I want to leave time for a Q&A. One is just to give you a sense of this broader scale strategy that I've been working on it with a bunch of names / logos you can see on this slide. Second, talk a bit about how that strategy was applied early on in the kind of first wave of COVID in Pakistan, and then talk a bit about what we're doing now as sadly the second wave may be emerging as well. It's sort of some ongoing work. So you'll get both a flavor of an abstract strategy, how it was applied, and then a sense of where we are moving next. In terms of sort of the scale consortium, this was basically a bunch of researchers, practitioners from a whole range of fields, a whole range of universities, which came together when the crisis was first unfolding, and really driven by this idea that you know, no one expertise is sufficient. We really need a bunch of individuals working together to try and address some of the problems we were seeing. And so let me give you an idea of what the scale strategy was. This was applied much more in Pakistan, but Jishnu has been doing a lot of work in India. We've talked a bit about this strategy with counterparts in Africa, and also talked a bit about the strategy in South Asia more broadly. So let me kind of give you the essence of what we were trying to do. And, you know, this was partially applied by at least some places, some of our partners, but to be honest, a lot of it is now more commonplace. Other places have started doing this as well. So our idea was very straightforward. There were kind of 3 sort of components to this, and I'll run through those 3 components. The first was this sense that, look, we are very much in a classic setup of decision-making under uncertainty. And when you have decision-making under uncertainty, you have to realize that whatever you do, you need to be building knowledge while you're operating. So you can't just rely on the accumulated stock of knowledge. You know, when COVID first started, we didn't have a good sense. We had some sense of the biology of the disease, some sense of the models behind it, but the standard error on the predictions was massively high. So you all saw that famous curve about sort of flattening the curve. If you put standard errors around that curve, that picture is far less impressive than we made it out to be in terms of the effectiveness in policies. And so our first thing was to say, look, we don't know, both frankly on the benefit and the cost side, we don't know how successful containment policies are, and we don't know the cost of any containment policy. And so whatever we do, you have to build measurement as you're doing it. And we were arguing that you should be collecting representative outcome data every couple of weeks on three main outcomes. One, COVID prevalence rates, to see if the policy you have in place is effective or the lack of a policy is costly. Non-COVID health outcomes. There's a lot of evidence over the last couple of months that things like vaccination in general, maternal mortality, infant mortality may have increased because people were essentially not going to hospitals if you have a lockdown policy. So let's measure how severe that is. And then also just socioeconomic impacts of COVID, which is what's happening basically in terms of poverty, food security, other issues that may be coming up as we navigate this space. And we propose collecting data through a series of tools like smart testing, robocalls, phone surveys, using Google Analytics as well to do this. So this was kind of sort of, if you will, element one in the strategy. Element two in the strategy, for lack of a better word, I'm going to call gridding. And the idea was a lot of countries were, and still are to some extent, trying to have a uniform policy everywhere. So the entire nation would have a singular policy. And we were saying, look, this is kind of very costly. It's like, imagine if you have a tumor in a certain part of your body and you decide you're going to irradiate your entire body. You don't need to. Right? And I'll show you some data which was suggesting that COVID was very localized. It wasn't uniformly present everywhere. So whatever policy you needed to have, you needed to grid it, if you will, or you needed to kind of split your region, your country, your state, your town even, into different geographical grids. So you could isolate and differentially apply, whether it was lockdown or not, or any containment policy, you could differentially apply to different grids and see what these were. In rural areas, this is very natural. A village is a closed environment typically, and you can think of a village as a singular grid. In urban areas, it's more complicated, but we were arguing that local policymakers have a sense of what's an isolatable area. So a neighborhood could be somewhat segregated from another neighborhood. So start thinking about doing that. We also encourage a lot of countries to say, use pre-existing grids, because we were trying to also overlay socioeconomic demographics to it. So for instance, we knew that denser areas would have more rapid spread. And so we were saying, look, if you overlaid, when you do population censuses, you already have, even within urban areas, natural subclusters of sampling that you do. Use the same subclusters so we could overlay already available demographic characteristics like population density or like the fraction of elderly in these areas. And so that was kind of the strategy of gridding. But the idea being is grids allow you to have more targeted therapies, so you could both maximize the health benefits and minimize the economic costs of policies. The third thing we did in the strategy was grading. And this is now, again, a lot of places are using this, but again, not as much as we thought they would and not as well as we hoped they would. So the idea was that you would basically have different levels of color coding. This still applies, sadly, even now, which is areas which you can think of the green now as areas which have low incidence, either never had high incidence or used to, but are pretty low, all the way down to red, which is where the disease is really spreading. And purple was an area where the disease was kind of beginning to fall. The curve was beginning to dip. And so you were in this restore phase. Now you can think of this phase, in some sense, you could think of post-summer and pre-winter as purple. Everything was purple. We were kind of in the restore phase. Sadly, now with the second phase, second wave emerging in most places, we're back to kind of yellow, orange, or red. And for us, it was very important, just like you do things like terrorism alert, it was very important that whatever you do, you broadcast what an area is in. So you can imagine this visual image I have. I'm showing you an area. This is an urban area. And I'm showing you that it's actually gridded into parts which are where infection has been detected and is spreading, the reds. But in the data, and I'll show you in a second some actual pictures, it was actually, this seems odd to say, why would a green be next to a red? But it turns out it was. There was a lot of geographical variation we were seeing. So this was very important. And I'll talk a bit about maybe in the Q&A why this might be the case. How is it possible to have a disease spreading in one area but be contained in a very proximate area? What does that mean? But if this is the reality, then you know policy response has to be color-coded. The reason it was important to publicly communicate this is, you know, a lot of countries started doing this. It was almost like, we don't want to create panic, so we won't tell people what to do. My own colleague, Matt Andrews, talks a lot about this in crises. That's a worse thing to do. Acting that you shouldn't communicate to citizens what's going on, especially in a crisis where a lot of the necessary action that needs to be taken is taken by citizens. So if I know I'm in a red area, then I'm going to be more cautious and try and bring it down. If I know I'm in a bordering a red area, I'll be more careful not to visit the red area. So these were important things to take into account. Unfortunately, most countries were very opaque in terms of communicating this. Again, because they thought somehow we'd have panic ensue. Our view is, and I think Matt's view is, that that's not actually in general a good policy. Open communication is much more important. Public communication is much more important. We're actually pushing for some of the places we work with to create a website where you show cities and towns with infection. Obviously, one key thing over here is you have to protect privacy of individuals. So you can't have the grid be so small and the grade be so specific that you reveal who's infected. This was happening in some of the countries we were working with, where individuals were being ostracized if they were infected. And I think that's terrible as well, because then people don't inform about infection or don't seek help in the way they should. So this was the kind of three main components to this strategy. And then for each of these things, we had specific actions in terms of what should you be doing in terms of testing, or what should you be doing in terms of surveys, what's the lockdown associated with each color code. And the idea was that this would kind of help us learn the effectiveness of different policies, and we could cycle back. This was important, so we started creating documents which are SOPs, like standard operating procedures, because a lot of policymakers were basically running really short on sleep, frankly. These guys were working 18-hour, 20-hour days. And so we were trying to make it very simple to say, guys, let's just have a very simple operating manual, which you could use in decision-making. We had part success in this and part failure, and I'll talk about to what extent this was adopted. My hope is now, in the second wave, a lot of the things we were saying in the first wave are actually showing up more in the second wave. I think with hindsight, people are they're a bit less panicked. There's a bit more stuff we know. So there's a bit more willingness to apply systematic processes like the ones we were raising, at least at that early stage. This is just an example of grading. So this is an actual town in Pakistan. And I'm showing you kind of some data about it. And you can already see kind of the color variation. And the legend is right there. So you can see green, which is zero infection, and red, which is more than 10% of the population is infected. And you can see it's actually not that uncommon to have red and green bordering each other. And that was a point I was making earlier. This is one urban area, and you already see in that urban area, there's a lot of geographical variation. The other thing to notice, which is interesting, is you don't see like hotspots in terms of red in one area. There's little reds everywhere, right? And that's telling you that basically, you know, the way the disease is spreading is not necessarily geographical proximity in the way we think. It's not that there's a red disease and that red disease kind of starts spreading from an epicenter of the disease like an earthquake would. It's actually, it's simultaneously showing up in different places. Now, there's reasons why that may be happening. Maybe you should be overlaying it on a different geographical space. If I overlaid, for instance, highways over here, maybe the disease, the red is around high traffic areas. Or maybe these are areas where a lot of the disease initially was imported. And so these are areas where someone from outside has come in, and that's where their house is, and that's where the disease is spreading. But again, from a policy perspective, this shows lots of local variation, which is fairly stable. You know, I've given you some sort of associated things. Like I said, in the things we were suggesting, we had specific operational procedures for what kind of testing you should be doing. We introduced in Pakistan the idea of pool testing, and I'll come back to that in a second, about sort of saving costs. There was an article by an ex-Nobel laureate who I won't mention because it's mutually embarrassing, who was arguing for universal testing in the US, which I think is a terrible idea because testing was a public good. So with tests being limited and insisting that rich countries should test everyone was just dumb when you could do pool testing and save a lot of money. And so we talked about that as well. But we had lots of ideas in terms of cost-effective, feasible ways of data collection, what kind of measures you could use in terms of physical distancing, what messages you would need, and what action you should be taking. So this was part of the operational manual, if you will. Let me draw a bit on in that time. Sorry, I'm going fast because I wanted to make sure I get through a bunch of stuff. I want to talk a bit about how we applied some of these ideas in Pakistan, what we found. There's some interesting findings there. This was in the kind of May to April wave. And I'll talk a bit about, like I said, what we're going to starting to do now in the second wave. Our idea was we worked with one of the states in Pakistan. We wanted to kind of do three things. One, improve the measurement analytics they were using. Two, inform policy, and kind of three, build capacity for the next round. I think we've reached modicum success in all three. In my own color coding, I would rate us probably around orange if green was good, kind of in where we were. And here's what we did. So first of all, we changed how testing was happening, both the sampling strategy. A lot of sampling that happens when people say we have a random sample, what a lot of countries mean is we have a whimsical sample. Random is not the same as whimsical. Right? When we say something is random, that has a very specific set of attributes which need to satisfy to truly be a representative or random sample. And so people were doing things like self-testing or going to a certain area, or some minister decides, I want to test this population. That's not random. That's purposeful, but whimsical. And so we kind of changed how the sampling was happening to get a true picture. We also started pooling, introducing pool testing, and that reduced the cost by about 60% of the procedure. We ended up testing about 12,000 individuals in this format in May of 2020 in one of the larger cities in Pakistan. And here's kind of some of the things we found. So this is the same picture I gave you, but kind of now zooming. Let me actually zoom in even more. This is just to give you an idea. This is one area in this town, and you can already see what I was saying in terms of the variation in that area, the kind of red, greens, and oranges all next to each other. So a lot of localized variation. The other thing is how effective was policy. So in this town, you see various lockdowns. So this is a time sort of longitudinal timestamp of prevalence, if you will. Our testing period is the first couple of weeks you see in blue. But what is more interesting is this red line. This was another indication of how severe the disease was. You should think of the red line as slightly delayed. So if you have an infection, eventually you get sick. And if you get sick, you eventually go to a hospital. If you go to a hospital, you have ventilators. There was a lot of politics around testing when we were working. So they stopped testing somewhere in mid-May. But the ventilator data we had from afterwards as well. And so this gives you already a sense that lockdowns in fact do work. So just to give you an idea, if you look at the red dashed line, think of this as disease prevalence delayed by about 2 weeks, right? And what you can start seeing is in Pakistan, the lockdown process happens. We argued basically using this data that the lockdown was effective in this town, partial lockdown. And you can see that during the period of the lockdown, which is the first couple of red bars you're seeing, both the lockdown and the easing of the lockdown, the blue line is jagged, but it stays stable. It's not going up. Remember, the norm over here is exponential growth. So the fact that this line is going up and down is great news, by the way. Because if you didn't do anything, normally, given the way the disease spread is, this should be an exponential growth function, and that's definitely not what this is looking like. However, you can see the exponential growth function if you look at the red line. So what happens in Pakistan when Eid hits, the lockdown gets lifted basically about mid-May, and then we have Eid, which is one of the largest celebrations. People get together and we kind of have a party, and you can see the consequences of that. This is a period between the 28th of May to basically the 9th of June. You see a period where there's no lockdown, everyone is opened up, and you see exactly what happens. The disease spikes, and then somewhere around late June, they imposed another lockdown. They called it a smart lockdown this time. It kind of followed what we were suggesting, which was it was partial. Not every place was locked down. Hotspots were locked down more than other areas, and you can see the disease beginning to drop. So this is sort of saying, look, policy really does work. These measures really do work. Even though they may be somewhat costly in terms of the economy. This is giving you some idea of disease profiles and demographics. We are very curious with who's more likely to get infected. What does that look like? Not surprisingly, not only do we know the elderly are more likely, have worse mortality outcomes when they're sick. It turns out in the data, the elderly were also more likely to get affected. And this was very interesting for us because in a context like Pakistan, you would think the elderly actually are less mobile. And so they should be more protected. But it turns out they were being exposed within households. So if everyone has to go say hi to the grandfather or the grandmother, then guess what? Every time you have those multiple highs, you have potential of infecting them. So we saw these increasing risk profiles on the elderly. We also saw people with pre-existing conditions were more likely to be infected. So again, these are what we're talking about is not necessarily morbidity outcomes, but susceptibility to be infected. So if you have a population which is has worse mortality outcomes and has higher susceptibility, that's a really bad combination. And that's exactly what we're seeing in Pakistan. People who are more susceptible and elderly were more likely to be infected, and also obviously turns out more likely to have worse consequences. We also found in our data that the infection was extremely localized. So what mattered, you were more likely to be infected if there was someone infected within 1 kilometer of you, but not within 2 kilometers of you. So it's really immediate distance which mattered, not, so it's if you think of these models, they have gravity equations, which is how far does one have to go to become safe? For us in this urban area, it turns out 2 kilometers made you safe, right? And that's sort of important to keep in mind in terms of how the disease will spread. This is also telling you why you could have a red area, but have green around it, because the spread decays really rapidly. Now, again, these are not patterns which may hold in other countries. This is saying something about the mobility in an area like this, that the mobility probably was limited geographically. We had a couple of insights emerging from this work. Some of these things are obvious, but I think it's important to reiterate them. It was very clear that the messaging had to be focused on the elderly. A lot of the public health messaging coming was kind of age independent or gender independent. And we sort of argued that said that was kind of a mistake. You had to basically you had to keep on reminding people that the elderly are more at risk, but then also have messaging to the young to say, you may be less at risk, but you can effectively kill your grandparents. It's a harsh way of saying it, but it's a stark way of saying it as well, to really make the responsibility on them, the onus on them. And that meant the messaging had to be targeted to them. And most of the messaging was not. It was just blanket statements about please wash your hands and please wear masks, and not about you, the youth, have a responsibility to protect your elders, right? And also making it very your elders, not just a generic category of elders, but literally the grandparents you see every Eid are at risk because you're trying to hug them too much, right? That sort of messaging. There was also a lot of focus on women. In our data, we found women, again, surprising for us because women have less mobility in a context like Pakistan. We found, if anything, infection rates were higher for women. And we thought what was happening was women may have more mobility, have limited mobility outside of the household, but guess if you're sick, who you go to? Right? So it was likely that women's were highly mobile within the household, and that made them more susceptible. So if one person falls sick, the person who's going to be taking care of them, giving them food, happens to be the mother in the household, and well, she's at risk. And so both protecting women in the household, but also recognizing that if they are primary health givers, they're also the ones who can enforce safety standards within the household. So making sure, hey, you better wash your hands before you come in here, or you better wear a mask before you come in here. Those kind of messaging, again, targeting women. A lot of these things have to do with how norms evolve in societies. And what we're trying to get was to say is, look, you should have your messaging filter through what the norms and socioeconomics in your society are, so that people who really can be responsible for these things are the ones who become champions of change in these contexts as well. I talked about the message about young hurting the elderly. I talked already about how population density was a strong predictor of disease spread. And so areas which were not infected, but highly dense, think of slums, for instance. Again, Pakistan has less of these, but if you're in India and you're in, say, Mumbai, you really need to be focusing on slums. Now, again, it's this political economy of the disease. Well, who cares about the poor? Well, guess what? You live right next to the poor. And slums are extremely highly dense, but not just that, they share things like public latrines. And so these are going to be spaces where disease is going to spread. There is a really interesting study to be written, and we're thinking about it, kind of a tale of two Punjabs, a comparison between Indian Punjab and Pakistani Punjab, which have shown very different, I think, long-term dynamics. And it could be that one of the differences is India tends to have a lot more larger cities with peripheral populations, or slums, if you will. And those could actually create more disease vectors as well. Let me kind of end with a bit of where we are. And let me show you some graphs now. This is now recent data. This is not our data, but data that the Pakistani government has been putting out. I think by and large, the levels may be off, but the trends are not in this data. But let me kind of tell you what's happening. And the interesting question over here, there's a lot of talk where Pakistanis think we're blessed. The case of Pakistan seems like we got off much better than most other countries did in the region, including India. Bangladesh, I know a bit less about. There are other countries like this, but a lot of African countries seems to have gotten off easier, or at least we think they have, but no one's quite really documented it. But let me first give you some numbers to say Pakistan may in fact be different. So here's Pakistan sort of since the beginning of the pandemic. This is official data by the government. The red line is actual cases detected. The blue line is number of tests conducted. Because one concern obviously is, as our hopefully outgoing president famously said, I wish we were testing less. That's why we have so many cases. That's obviously a nonsensical thing to have said. But low cases in emerging economies could be an indication of not testing. This is not the case in Pakistan. So you should look at the purple line. And the purple line says, the blue line is pretty high. So they're testing about 7,000 to 8,000 per day. That's still not terribly high, but it's decent enough to give you a sample. And what you can see is very interesting is you can see this first wave coming up in June, peaking in June. Again, you can see this is a period where we had relaxed lockdowns and stuff. Right, and you can see really hitting the peak. And then there's just a natural drop. It's not, we can't quite understand what happened. There is an effective policy, but basically there is a drop, the red line drops drastically. And now you're beginning to see, if you look at the November line right at the end of the right side, you can start seeing a rise increasing. But by the way, this isn't a lot. In the large scheme of things, remember, this is a country, if you want to normalize these numbers, these are absolute numbers, Pakistan is around the size of the US, right? We're hitting what, 100,000 our latest number. Pakistan is hitting about 7,000 or 8,000, right? So it is, but again, we're testing a lot less. The prevalence rate may not be that different. It's about 4% or something, that may be not terribly different. But at least it's telling you these time patterns, and it's beginning to show you the second peak beginning to emerge. The whole game in Pakistan now is, can we arrest this increase, which is happening on the red line, and prevent what happened in June? Or are we going to go the same route? And this may be even worse, because in cold weather, you're probably going to have worse viral loads happening because people are in closer proximity to each other. By the way, this is another puzzle in Pakistan. So one puzzle is, was disease prevalence lower? The second puzzle is, conditional on being ill, was mortality rate different? And these are mortality numbers. These are absolute numbers. This is COVID mortality, at least recorded mortality. Again, this could be an underestimate, maybe by a couple of factors, but still these numbers are pretty low. The total number of people who died in COVID, officially statistics, is less than 7,000. Right? So again, shockingly low numbers. Are these attributable to a lower population? It's very hard to hide mortality. Right? You can hide morbidity, but hiding mortality is difficult. So my guess is these numbers may be somewhat underestimated, but probably not drastically. So these are not likely off by an order of 10. They might be off by maybe an order of 2 if people are dying and not coming into hospitals, or so on and so forth. There is very interesting patterns by COVID mortality by age. Not surprisingly, you see younger are more likely to be infected, at least in this data. In the overall aggregate data that we have in Pakistan, but the older are ones who are most likely to die. There's more male mortality than female mortality. These are consistent with kind of global trends on this. The three questions we're going to ask now, and then I'll end, is we're basically trying to corroborate these numbers. So we're trying to say, is Pakistan different? So how has the disease truly evolved in the country? We're going back to administrative data, tests done, and trying to kind of sift out, if you will, properly done sampling versus just numbers which are systematically done. Remember, Pakistan is a country where it's very easy to get tested if you can pay. So with for about $40, you can get yourself tested, right? And that's pretty cheap. And anyone, you don't need some elaborate thing. You can get test results within hours. There are lots of private labs testing. And so a lot of the testing in Pakistan may be self-selected samples. And you have to ask yourself, who is it that is paying 5 or 6 or 7,000 rupees to get tested? Is it just the rich? Is it those who are traveling, and so on and so forth? So sifting through the data to see what is actual numbers in terms of prevalence, how has it evolved, what is mortality outcomes, not just relying on official hospital data, but doing things like going to cemeteries and looking at burial records. Are we seeing excess mortality in this country? That could be hidden numbers, right? Again, everyone is going to get buried. Pakistan is a country where it's burials, not cremation mostly. And so you could literally go to graveyards and start counting fresh graves or the equivalent of that. And that'll give you a sense of, compared to say September of last year, what does September of this year look like? And if there's a difference, then that's probably COVID related, or at least COVID induced, perhaps not as a consequence of COVID, but as at least COVID, as in being sick because of COVID, but because of COVID, you couldn't get to hospital, you were diabetic and you actually died. So either way, it's either a direct COVID effect or an indirect COVID effect. So those would be useful to kind of get at. And then also morbidity outcomes, not just mortality, but how often are you sick? How long did you stay? Did you need a ventilator or not? Did you stay at home mostly? That kind of stuff. Did it take 2 weeks or a week? This sort of data, and systematically getting this data. This data is going to be pretty critical for us to get nailed down ASAP as we go into the second wave. And our hope is that once we know these statistics are a bit better, we can go back to the policy kind of that I introduced in the beginning and now implement it in a more systematic way. I think that's it. Sorry, I was talking pretty fast, but I thought there was lots of stuff to say. Let's open up. Let me stop sharing this slide.
Okay. Thank you, Asim. So now we will open Q&As. We will do it in batches of 3. We have one question from John Hoven, and please feel free to write your questions in the chat or raise your hand. John, would you like to ask your question, or I can read it if you want. What are you, okay.
What are you learning about how local citizens are trying to protect themselves from this in the dense urban slums where it's impractical to social distance, or in remote villages?
Yeah, that's a great question, John. It's a great question, and I'm going to disappoint you by saying I don't know very well about this, unfortunately, because this is precisely the things we should be measuring, but we're not. The anecdotal evidence, unfortunately, is depressing. The anecdotal evidence is that while initially there was more protection, people were actually wearing masks. You could see them visually, even in poor areas. Masks are not that expensive. Hand washing is not terribly expensive. Very soon, there was this view that Pakistan is different, at least, and we're safe, and that stopped happening. And even now, despite kind of the messaging around it, I think there is a sense in which, especially amongst the poor, that, you know, it's fine, we'll take the risk. And so I think the answer is not great at all. In rural areas, I'm less concerned precisely because they are more remote, that in some sense disease vectors are less likely to spread as easily. I think the big issue is going to be urban, dense places. But like I said, in Pakistan, we don't have the kind of slums that you see in India, that level of density and that level of concentration. We do, but you know, I think the situation is somewhat less dire than it would be in some of the other places in South Asia. But I think the question is spot on. There is trying to be messaging from the government about masks again. I wish we did things like, for instance, in Africa, there are things like Veronica buckets where you kind of have disinfectants in public places where people can, in high traffic public places, where you just make free disinfectant available, or just hand washing stations available where people can at least wash and disinfect themselves, and hopefully also kind of masks available. But I'm not seeing a lot of that, unfortunately.
Thank you. Now we have a question from Karim.
Yeah, thank you, Asim, for that. That was great. My question is really on the collective action that was taken by these multi-universities and multi-organizations as a way to deal with such complex policy issues. So from your experience, what worked well, what were the challenges, and how do you see the future of collective action moving forward?
That's a great question, Kareem. Thank you. Let me start close to home, which is amongst academics. Look, the one thing COVID revealed to me is that our fields, I've always known economics has silos. We fight with each other constantly. And you have a sense that other fields have silos as well between fields. Gosh, if there's one time when those silos have been costly, it's COVID. It's just ridiculous. The kind of lack of cooperation across fields, or at least not, I shouldn't say lack of cooperation, that's an unfair word. The pre-existing or the initial conditions for cooperation were pretty bad. We all publish in our own journals, we all do our own things, we all think we have our own expertise. And that took a while for us to get through. To be fair to all these fields, once the ball started rolling, it was pretty amazing how quickly things started falling into shape. Because also when you think of collaboration, it's also their nodes of influence. So as long as you can connect 2 or 3 important nodes of influence, they can then bring into the collective, if you will, a wider set of folk. Also, I think the need was desperate. I think in the beginning, no offense to my epidemiologist friends, in the beginning, there was a heyday for epidemiologists, this whole curve. I was sick of seeing that little flattening the curve business. But to be honest, those models were really bad. And what upset us when we were looking at it as statisticians or people who do sampling theory is what I alluded to earlier, there was no standard error around those curves. So this idea that somehow we could easily flatten the curve, and this beautiful picture, which every bloody media channel in the US was showing to say flattening the curve, was extremely misleading because we had no idea about these parameters, and even a small amount of imprecision in these parameters changes the shape of the curve drastically. You can imagine these are exponential growth functions. So a few percentage, what is an acceptable standard error in an empirical estimate blows up really quickly. And we were getting really frustrated by people applying these models blindly. I think over time, people started realizing these models were really way off in terms of their predictions. And I think that led to a bit more of acceptance across other fields. It also became clear that it's not just about health anymore. You're causing consequences on other things like the economy as well. What's the future going forward? This is within academia, then I'll talk a bit more broadly going forward on that. I don't know, honestly. So far, our consortium has maintained. We're excited about kind of working together. Whether we split into silos again in the next wave, I don't know. I'm optimistic that it won't happen. There's also then collaboration between academia and the world of practice. That was very hard. And this is coming back to Shada's question as well, which is kind of the capacity to implement these things, right? Look, and I don't mean this in a bad way. When we first started engaging with policymakers, more or less every policymaker I talked to was like a headless chicken running wild. A well-meaning headless chicken. They were actually, for a first time, I was amazed at the spirit of these individuals. They were really putting themselves out there, risking everything, getting no sleep, but no direction, constant panic, constant sense of today we'll do this, tomorrow we'll do this, let's go test this population, let's go test that population. And we were like saying, guys, just relax. And this is another, I think, discredit we did. When you confront people with exponential growth rate, they somehow think that their effort needs to be exponentially increasing as well. And that's not possible. It just doesn't happen. And so instead of having a systematic, well thought out effort, we were just cycling back and forth in whatever the wacky idea of today was, whatever magic bullet you thought today would help. That was extremely distracting. What was also distracting was there was a lot of insecurity. A lot of countries saw this. This became political very quickly. It's not just the US between masks and not masks. Every country had its own version of party A promoting one strategy of locking down and party B promoting another strategy. In Pakistan, it actually happened at the provincial versus federal level. The provincial level, for whatever reason, was more run by the health guys, and they wanted to lock every damn thing down. The federal level was much more worried about macroeconomic consequences, and they wanted to start opening up as fast as they could. And so there was a lot of tension there. I've seen this happen in Latin America in interesting ways as well, in other countries too. What I don't know is the second wave going to be different? In the second wave, are we done with our panic? Do we feel we have more space? I think countries which handle itself or through luck or whatever better, like Pakistan, feel at least right now they have more mental space to act and feel that they can implement something more systematic. I don't know countries like the US, which just as we know, what's happened in the US, and even if we have the new administration coming up in place, will they be able to implement, or will they be able to get rid of the political baggage? Will masks still be political in the US or not? I don't know. And Shada kind of partly answered your question, but just to do a bit more, you're right. Look, this is a big issue. The managerial capacity of countries to handle these sort of things. We tried to, so my colleague Adnan, who kind of teaches public management, and also people like Matt Andrews, who I refer to, have a lot to say on this. I think our idea was keep the message as simple as you can, don't get into specifics, and let it be decentralized. But it's a challenge. I think your question is spot on. I do think they've built a lot more capacity now than they had, even in 4 months. The kind of ability to absorb, and look, I should give credit. The health department in Punjab, in a matter of days, managed to train over 100 health workers to do randomized testing. That's remarkable. That's credit-worthy. It's remarkable, especially when they're exposing these individuals to potential harm's way. And so, you know, I have nothing but praise for the bureaucracies in terms of the effort and the intention. I'm hoping now that'll come with a bit of thoughtfulness as well.
Okay, yeah, we have one last question from Barun. He's asking, how confident can we be about the impact of the various policy prescriptions in Pakistan and other countries? I believe we are seeing similar levels of spread in states with very different strictness of policy, at least in the USA.
Yeah, it's hard. It's a good question, Varun. I think there's a lot of still data rumors. I don't know how else to say it. Like, rumors are easy to refute, but rumors which are half empirical are much harder. There's lots of bad empirics here. There's lots of, and the devil really is in the details. I mean, to give you an example, something as simple as what is prevalence rate? So let's take a very simple question. Was my policy effective in preventing disease spread? That's like the first order question you would want to know. The problem in answering that question is it relies on a representative sampling measure of prevalence. Now, how do we get that? Take something like, take our community. Every day we get a nice little email from Harvard saying, this is the number of diseases we have. This is the Massachusetts infection rate. We're not doing representative testing in Massachusetts. We aren't, right? We are testing people who show up to work, for instance. That's one source. It's very difficult to get tested, right? So a lot of these numbers, I'm not sure, even in a place like Massachusetts, I could be wrong, I haven't looked into the numbers. My worry is if you're not doing proper testing or prevalence measurement, you can never quite know what the effect of a policy was. The other problem is the policy impact shows up with lags. And when you have exponential growth rates, again, coming back to this, you need to get the timing of your measurement and the timing of your policy really correct, right? It's not like a broadly, you know, in the month of May, we broadly did this. In the month of June, this broadly happened. That may be too crude for you to pick up effect. So my personal kind of look at the literature, both in the Pakistani data and otherwise, is actually policies are very effective. In fact, they are, right? Surprisingly effective. But, you know, the evidence is murky enough that some people who want to claim otherwise can happily do so. As well. I also think when you look at historical records, you know, the Spanish flu kind of records, it shows the same thing in the longer term in the aggregate, right? And so that said, I do think politically we need to set up processes in place where we can demonstrate that. Because again, the nuances may matter, right? How severe a lockdown do you really need? Do you need to close down just only the bars and restaurants, or should you be closing down schools as well? I mean, those sort of specifics will depend on the socioeconomics, the demographics, the migratory patterns, the movement patterns of particular places, and frankly, the viral load in particular places. And that's going to require fairly localized policy response and measurement in the way that I alluded to earlier. I think we have the capacity to do so. I don't think I'm arguing for, like I said, measuring everyone. I think small, sensible sampling can actually get these things measured and done well. And that's kind of my pitch for, I mean, if there's ever a pitch for what the stuff we teach in the Kennedy School in terms of evidence-based decision-making having real impact, it's now.
Great. Thank you so much, Asim, for your presentation. It was really timely, and I hope that more countries and places will be able to pick up these smart containment approaches. And thank you all for your great questions and for your engagement in the session today. We hope that you'll join us next Friday, November 20th, for the presentation with Jenny Perlman-Robinson and Molly Curtis from the Brookings Institution. So thank you all again for your time, and we look forward to seeing you again.
One thing I should say, Sarah, is if anyone's interested in this, CID is trying to put together a larger proposal, kind of a multi-field, multi-discipline 4 to 5 year proposal on COVID, because I think it's going to unfortunately be here with us to stay. And so if anyone of you are interested, you should reach out to the CID team. Adriana probably is the right person to kind of talk about that. Great. Thanks, everyone.
Sure. Great. Thank you, everyone.